I'm Dr. Sarita. I'll be discussing spinal cord injury and its clinical correlation. Transverse section of spinal cord consists of gray matter and white matter. Gray matter is head-shaped, present internally, and white matter surrounds the gray matter. Gray matter consists of central canal which traverses throughout the extent of spinal cord. Gray matter has an anterior horn and a posterior horn. Anterior horn is motor in function. Posterior horn or dorsal horn is sensory in function. Anterior horn or ventral horn gives rise to ventral roots, the motor roots. Posterior horn or dorsal horn gives rise to the dorsal roots, and dorsal roots is sensory in function. It is associated with dorsal root ganglion. Spinal nerve is formed by the union of ventral roots and dorsal root, which is mixed in function. Both it has sensory and motor fibers. One spinal segment gives rise to one pair of spinal nerves. Anterior roots or ventral roots, which arise from the anterior horn. Dorsal roots or posterior root, which arises from the posterior horn, forms a single pair of spinal nerve. And a single pair of spinal nerve forms one spinal segment. Each spinal nerve further divides into an anterior ramus or ventral ramus, a posterior ramus or a dorsal ramus, which are mixed nerves. Coming to the gray matter and white matter of the spinal cord. Gray matter has anterior gray column or ventral gray column, which consists of number of important nuclei. Medially, it has two groups of nucleus, ventromedially and dorsomedially. This group of nucleus is present throughout the extent of spinal cord, and they mainly innervate the erector spinae group of muscles, which are the extensors of the vertebral column. In the lateral part of the anterior gray column, we have three groups of nucleus: ventrolateral, dorsolateral, and retrodorsolateral group of nucleus. This group of nucleus is basically seen in the cervical enlargement, which innervates the upper limb muscles and structures related to it, and also seen in lumbosacral region, which innervates the lower limb. We have also seen the central group of nucleus in the anterior gray column. We have two groups of nucleus, accessory nucleus and phrenic nucleus, which is only present in the cervical part of the spinal cord. Accessory nucleus innervates the trapezium and sternocleidomastoid. Phrenic nucleus supplies the diaphragm. Coming to the posterior gray column, which are sensory in function, this group of nucleus mainly gives rise to the ascending or sensory tracts. There are three major groups: substantia nigra occupying the apex of the posterior horn, nucleus propriosus, and dorsal nucleus or Clark's nucleus. Substantia gelatinosa and nucleus propriosus is present throughout the extent of the spinal cord. Dorsal nucleus or Clark's nucleus is present from T1 to L2 level, mainly gives rise to posterior spinocerebellar tracts. Intermediate gray column has two groups, medial and lateral. An intermediate gray column is present in the thoracolumbar region from T1 to L2 and in the sacral segments S2, S3 and S4. Thoracolumbar region gives rise to the preganglionic sympathetic fibers, and the sacral segments give rise to the preganglionic parasympathetic segment or parasympathetic fibers. White matter consists of ascending tracts which are sensory in function. descending tracts which are motor in function. Coming to the ascending tracts or sensory tracts, in the dorsal funiculus we have two major tracts, fasciculus gracilis and fasciculus cuneatus. These two tracts mainly carry fine touch, vibration and proprioceptive impulses. In the lateral and anterior funiculus of white matter, two important tracts, lateral and anterior spinothalamic tract. Lateral spinothalamic tract carries pain and temperature. Anterior spinothalamic tract carries crude touch. Then we have two important tracts, dorsal spinocerebellar or posterior spinocerebellar, anterior spinocerebellar or ventral spinocerebellar tracts. These carry mainly proprioceptive impulses to the cerebellum. Coming to the descending tracts or the motor tracts, the important tracts are lateral corticospinal tract and ventral corticospinal tract. This belongs to the pyramidal tracts. Then we have extrapyramidal tract, that is rubrospinal tract. These three important tracts are mainly concerned with voluntary motor pathway, mainly influences the flexor musculature and inhibits the extensor musculature. Lateral corticospinal tract and rubrospinal tract are present throughout the extent of spinal cord, whereas ventral corticospinal tract is present only up to the cervical region. Then we have lateral vestibulospinal tract and ventral reticulospinal tract. Lateral vestibulospinal tract starts from the vestibular nucleus. Ventral reticulospinal tract starts from the pontine reticular formation. Both these tracts are concerned with voluntary motor pathway, mainly influences the extensor musculature and inhibits the flexor musculature. Then we have medial vestibulospinal tract or the continuation of medial longitudinal fasciculus. It's also concerned with head and neck musculature. Lateral reticulospinal tract starts from the medulla reticular formation, mainly concerned with autonomic nervous system, mainly influences the intermediate gray. Developmental anomalies related to spine and spinal cord. Normal spine where bone and cord are normal. Osseous defect is known as spina bifida occulta. Osseous defect showing the protrusion of the meninges known as meningocele. Osseous defect showing the protrusion of meninges and the spinal cord, which is known as meningomyelocele. Clinical correlation of various spinal cord injuries. Damage to the spinal cord is associated with the loss of function. 1. Paralysis, that is loss of function. Paresthesia, loss of sensory function. Flaccid paralysis, motor loss, which is lower motor neuron lesion. Spastic paralysis is an upper motor neuron lesion. Body regions below the lesion are the quadriplegia, spinal cord injury wherein it involves four limbs paralysis. Paraplegia or spinal cord injury which involves two limbs, mainly the lower limb paralysis. Hemiplegia is one side paralysis of the body, mainly due to the injury in the internal capsule that is present in the brain. Phrenic nerve palsy is at the level of C4 where phrenic nerve usually arises. Phrenic nerve injury may occur from cardiothoracic surgery as a phrenic nerve traverses along the right and left borders of the pericardium, cervical spondylosis, multiple sclerosis, myopathies and immunological diseases. It may be a unilateral diaphragmatic paralysis which can be iatrogenic, and bilateral paralysis may be motor neuron disease. In a bilateral paralysis, patient dies due to the paralysis of the diaphragm. Poliomyelitis involving anterior horn cells, that is the motor neurons, caused mainly by polioviruses. It mainly involves the lower motor neuron paralysis. It is characterized by flaccid paralysis of the muscles innervated by motor neurons of the spinal cord. Asymmetrical paralysis that is most often involves the legs. Spinal cord injuries or causes can be mainly due to the road accidents, bullet or stab injuries, traumatic and sport injuries, electrical shocks, fall from the great height, and landing on the head. The seventh and the most important is ischemia due to the lack of blood supply. Types of spinal cord injuries can be complete or incomplete. Damage to the spinal cord that causes temporary or permanent changes in its function. It is a destructive neurological and pathological state that causes major motor, sensory, and autonomic dysfunction. In complete spinal cord injury, the victim experiences no function below the injury. An incomplete injury indicates that there is some function below the injury site. Types of spinal cord injury are mainly two types: complete spinal cord injuries, tetraplegia or quadriplegia, paralysis of all the four limbs, paraplegia involving the paralysis of lower limbs. Incomplete spinal cord injuries are six types: central cord syndrome, anterior cord syndrome, posterior cord syndrome, brown squat syndrome, cauda equina syndrome, and conus medullaris. Incomplete spinal cord injuries are categorized into six syndromes. This is normal. The first one is central cord syndrome, involving the central part of spinal cord. The second one is brown squat syndrome, involving one half of the spinal cord. The third is posterior cord syndrome, involving the posterior part of the spinal cord. And the fourth one is anterior cord syndrome, involving the anterior part of the spinal cord. The fifth one is cauda equina syndrome, which involves the cauda equina of the spinal cord. In cauda equina syndrome, it involves the compression of lumbar and sacral nerve rootlets below the L1 spinal cord. The sixth is conus medullaris syndrome, which involves the damage of tapering distal end of spinal cord, that is at the level of T12 region. Complete spinal cord syndromes are two types: tetraplegia or quadriplegia, injury at C4, injury at C6 can involve tetraplegia and quadriplegia. Injury of spinal cord at T6 or L1 injury can lead to paraplegia. So two types of complete spinal cord syndromes. Coming to the incomplete spinal cord injuries, that is the brown squat syndrome. Hemisection of the spinal cord. The area of cord damage is one half of the spinal cord. A rare type of incomplete spinal cord injury where only one side of the spinal cord is damaged. Neurological condition is characterized by lesion of half of spinal cord, and it may be due to the important causes. It can be due to trauma, gunshot wound injuries, spinal cord tumors, and ischemia. In brown squat syndrome, the motor defects, ipsilateral spastic paralysis, that is leading to the lesion of corticospinal tract. Sensory defects can be dorsal column tracts, ipsilateral loss of fine touch, proprioception, and vibration sensation. spinothalamic tract laterally mean loss of pain, temperature, and crude touch on the contralateral side. Coming to the next incomplete spinal cord syndrome, that is central cord syndrome. Area of cord damage, mainly due to the acute hyperextension or injury in an older patient with cervical spondylitis or canal stenosis. Clinical presentation involves the affects the central part impacting the corticospinal tract. The upper extremity loss is more than lower extremity. Variable sensory loss is pain and temperature often affected, that is lateral spinothalamic tract. Patients have more upper limb involvement relative to the extent of lower limb involvement. Autonomic presentation is mainly due to the intermediate gray column. It can be due, it can involve sexual dysfunction, bladder and bowel dysfunction is mainly due to the intermediate gray zone. Anterior cord syndrome, the area of cord damage. Anterior cord syndrome has a worst prognosis, etiologically affecting the anterior two-thirds of the spinal cord, mainly due to the occlusion of anterior spinal artery, may be due to emboli, post-surgery complications. Flexion injuries can also cause this syndrome. Clinical presentation is paraplegia is affected due to the corticospinal tract and anterior horn cells. Sensory loss may be pain and temperature sensation is impaired at or below due to the lateral spinothalamic tract. Autonomic presentations may also be involved, that is sexual dysfunction, bladder and bowel dysfunction is due to the intermediate gray column zone. Dorsal column are spared, that is fine touch, vibration and proprioceptive impulses are intact. Posterior cord syndrome is very rare, etiology being compression of the tumor by tumors, trauma, infarction of posterior spinal artery, that is vascular occlusions. It may involve even during the tabes dorsalis. The area of cord damage, mainly it involves a sensory impairment is ipsilateral, loss of fine touch, proprioceptive and vibration sensation and 2-point discrimination below the lesion level as dorsal column is involved. They will also have positive rhombus sign with sensory ataxia. Pain and temperature sensations and motor functions are spared. Cauda equina syndrome or horsetail syndrome or damage below L1 spinal cord. Compression of spinal nerves and spinal nerve rootlets of the cauda equina, especially in the lumbar segments and sacral segments. The cord is spared. The important features is flaccid paralysis of lower limbs, retention of urine, involvement of S2 and S3 segments, bowel dysfunction, saddle anesthesia, sexual dysfunction associated with trauma, malignancy, and lumbar disc disease. Treatment mainly involves early surgical decompression within 24 hours is a must. Cauda equina syndrome or lateral cord syndrome, damage at the level of T12. It is characterized by damage to the conus medullaris involving the lumbar and sacral roots within the vertebral column. Etiology may be trauma or tumors. Clinical presentation is lower extremity plastic paralysis, saddle anesthesia, bowel and bladder dysfunction. The main treatment also involves early decompression surgery to avoid poor outcomes during recovery. Tabes dorsalis is a late consequence of neurosyphilis or tertiary syphilis. Its symptoms and signs is similar to the posterior cord syndrome. Most often it involves the dorsal roots and dorsal column, bilateral damage of affecting the legs. Clinical presentation involves loss of position, vibration sensation, 2-point discrimination on the same side below the level of lesion, locar ataxia. Syringomyelia. Two forms of syringomyelia. It can be congenital or acquired degenerative disease of gray and white commissure, usually seen in the cervical part of the spinal cord. Cavitations are seen in the gray commissure, enlargement of the central canal, destroying the crossing over of spinothalamic tracts in the white commissure. The clinical features are bilateral loss of pain and temperature, but preservation of light touch and proprioceptive impulses in the upper limb. Complete spinal cord injuries are one of the examples of catastrophic injury. The most extreme cases typically involve the paraplegia, paralysis of the lower part of the body, or quadriplegia, paralysis of the upper limbs and lower limbs. Four types of spinal cord trauma. It can be in the cervical region, in the thoracic region, lumbar region, and in the sacral region. Complete spinal cord injuries is common cause of permanent disability and death in the children and adults. Describes as a loss of sensory and motor function below the level of injury. So complete spinal cord injury, transection of spinal cord injury at the level of from C1 to C8 or above T1. It can lead to quadriplegia, results in paralysis of all the four limbs. Transection of spinal cord injury at T1 segments and below can lead to paraplegia. So cervical part can lead to tetraplegia at C4 and C6 level. The thoracic part at T6 level or below can lead to paraplegia. Injury at the level of lumbar or sacral or coccygeal can also lead to paraplegia. Coming to the important diagnosis and treating the spinal cord injuries. Radiographic evaluation is a must using an X-ray or CT scan or MRI can determine the damage of spinal column is located. To this date, there is no definitive method of reversing a spinal cord injury. Once the injury itself has established, therapy is initiated. Therapy is often long-term and consists of both physical and occupational therapy along with mental and health therapy. Emotional therapy for the patient and family is often needed because it is such a dramatic change in their lifestyle. Thank you very much.